Good morning, good afternoon, and good evening, everyone. My name is Andrea Caputo Svensson, Global Health Advisor at REACT and co-coordinator of the international work at Antibiotic Smart Sweden. Thank you for joining this initiative on impactful approaches for community-wide engagement on antibiotic resistance, organized by Uppsala Antibiotic Center, REACT, and Antibiotic Smart Sweden. We also want to thank the Swedish International Development Cooperation Agency, Vinnova, and Uppsala University for funding support. With this initiative, we seek to raise awareness and help promote a systematic and meaningful engagement of communities and civil society groups as key stakeholders in the global response to antibiotic resistance. It also aims at sharing experiences and learnings from experts in the field, as well as explore opportunities to strengthen community engagement in the global political agendas. This meeting series will feature two online webinars. Today, where we will discuss different approaches to community engagement on antibiotic resistance across the globe, and in a second webinar on October 25th, where we're gonna dive deeper into evaluation and impact of community engagement on antibiotic resistance. Finally, there will also be a workshop on November 29, where the take-home messages of the webinars will be discussed further, as well as challenges and potential solutions, and next steps will be outlined. I would also like to mention that this webinar is being recorded and it will be made available on REACT's website. And now, it is my pleasure to introduce you, my colleagues and moderator of this webinar, Kerstin Åkerfeldt, policy expert at REACT. Kerstin has an academic background in political science and international studies, and has worked many years as a policy analyst and advocate in the humanitarian and infectious diseases sector, with a focus on HIV, TB, and malaria. At REACT, she mainly focuses on global governance of antibiotic resistance and sustainable health financing. Kerstin, the floor is yours.
Thank you, Andrea, for the introduction. I'm really pleased to be here today. Over the years, I've seen communities do phenomenal work in the fight against infectious diseases, and community engagement has been critical for the success of many global health initiatives, and is also really very much needed in the space of antibiotic resistance, of course. So community and civil society engagement is at the heart of many of the activities that REACT carries out. So just before introducing you to our speakers, I will take just a few minutes to introduce you to REACT and give you a quick glance of some of the work on community engagement that REACT has been doing over the years. So REACT is a global network founded in 2005 that advocates for the adoption of a holistic view of the problem of antibiotic resistance and solutions that engage all of society. So next slide, please. The first example is from our colleagues in REACT Asia Pacific, where one of the community engagement and activities they have initiated is at the Aspects Clubs, the Antibiotic Stewardship and Prevention of Infection in Communities Clubs. This youth engagement initiative started in 2018 and is a model for engaging university-level arts and science students in southern India. And the objective is to spread awareness of antibiotic resistance and promote infection prevention and measures in their communities. Currently, there are clubs in 16 colleges through this initiative. Next slide, please. And College in REACT Africa have over the years been engaging and working with communities both in Zambia and Kenya to raise awareness and disseminate messages about antibiotic resistance. These initiatives have sensitized mothers seeking services from health clinics on the proper use of antibiotics and build capacity among students on antibiotic resistance. And one of the key entry points for reaching the community has also been to engage in the faith-based health sector and working with religious leaders and groups to spread knowledge through their platforms. And last but not least, next slide, please. In Latin America, our colleagues there have also started the Empowered Communities Initiative in 2021. This initiative provides a platform for dialogue and sharing the knowledge to address antimicrobial resistance from a One Health approach, and doing that between communities within the region. So now, without further ado, let's start today's conversation about approaches to community engagement on antibiotic resistance across the globe. Here, just first, are some common starting points to help us frame today's session. Antibiotic resistance is one of the major current global health challenges, leading to the deaths of more than 1.2 million people every year. And given its complex nature, antibiotic resistance cannot be solved by single actors in isolation, but requires a whole of society response. Community and civil society mobilization is especially critical for promoting people-centered health services, supporting quality of services, assuring the sustainability of advocacy, and ensuring the responsiveness of health systems overall. So community representatives with the potential to anchor initiatives that address antibiotic resistance and create the bottom-up action, such as participation in decision-making, governance, service delivery, are often not mobilized, and that results in missed opportunities. So, as you know, community engagement can take many shapes and forms, as you will hear from our speakers today. Next slide, please. So in today's webinar, we'll explore approaches and key learnings from community engagement initiatives on antibiotic resistance and related fields. We have 4 short keynotes, which will be followed by a panel discussion, and we will finish with a Q&A with questions from you online participants. Now, so first, it's my pleasure to introduce you to our experts for today's conversation. Our first speaker today is Dr. Camilla Björn. So Camilla, warm welcome. Camilla is one of the leaders of Antibiotic Smart Sweden, and she works as a researcher and project leader at the governmentally owned RISE Research Institutes of Sweden, where she also leads their focus area infection management. Camilla, the floor is yours.
Thank you so much, Kerstin. See if this works. Can you see my screen?
Yes.
Great, thank you so much. So, Antibiotic Smart Sweden is an initiative funded by the Sweden Innovation Agency Vinnova and participating partners. And we use a mission-oriented approach where different sectors and organizations and actors work together with a portfolio of different activities all towards a common, bold, and inspirational mission in order to meet a grand societal challenge, which in our case is antibiotic resistance, or AMR. And our mission, or perhaps you call it a vision, is Antibiotic Smart Sweden. And that is a society where everyone helps to keep antibiotics working and saving lives. And Antibiotic Smart Sweden is led by Public Health Agency of Sweden, together with RISE, Research Institute of Sweden, and together with REACT, Action on Antibiotic Resistance, and STRAMA, the Swedish Strategic Program Against Antibiotic Resistance, the 4 organizations together form the core team of Antibiotic Smart Sweden. And we also have 2 municipalities and 4 regions as our participating partners. But in addition, we collaborate with many, many other organizations and community representatives. But before continuing, some brief words about the Swedish model of government, which consists of 3 levels. And at the national level, we have the Swedish government, and then Sweden is divided into 21 regions or counties, and these are responsible for healthcare and public transport, etc. And then at the local level, Sweden is divided into 290 municipalities, which are responsible for a broad range of public services. So to achieve the mission of an Antibiotic Smart Sweden, we want to inspire and motivate all parts of society to engage and to help them understand their role and how they can contribute. And we want to build knowledge and create structures for individuals and organizations to make antibiotic smart choices. That is to prevent transmission of infections and to use antibiotics wisely. And we want to do this together with the society. And central in this work has been the development of antibiotic smart criteria, or criteria for antibiotic smart regions and municipalities and their different sectors, as can be seen in this figure. And these criteria have been developed together with the representative from the different area for which the criteria will be used, which is of course very important for us. And the criteria function as kind of a toolbox for systematic improvement work for important areas to address within each of these levels or sectors. And generally, the criteria covers organization and collaboration, measurement and follow-up, routines and working methods, education and professional development. And the number of criteria varies from sector to sector, but ranges from 5 to 20. But to give you a bit more specific, to give you some examples of how the criteria could look like, I will give you some examples from the municipalities. And then at the governance level, criteria include to make a political decision and that the municipality and its sectors should work for antibiotic smartness, and also to use AMR criteria for procurement of food. And criteria for elderly care includes, for example, measurements of healthcare associated infection and antibiotic treatments at the facility, and also set up an action plan based on the results. And for preschools, criteria include to appoint one of the staff as a hygiene representative who can support the implementation and follow-up of infection prevention routines, and also to perform educational activities for children. And the criteria for school include, for example, competence development for staff and educational activities for students. And for water and wastewater organization, criteria include measurements of selected antibiotics and bacteria in outgoing water from the treatment plants. So the criteria have or are now pilot tested at more than 60 different sites all over Sweden. And the criteria are then evaluated and revised together with the pilot sites. And now we prepare for a wider rollout of the criteria next year. And there we will also introduce the possibility to be designated antibiotic smart if you fulfill the criteria. So antibiotic smart municipality, region, or organization such as school or elderly care facility, for example. And we also have discussions to expand the criteria to other relevant areas as well, for example, veterinary sector. And in parallel to this, other work is also ongoing at Antibiotic Smart Sweden. For example, we want to engage citizens, and we want to do that in a more structured, systematic way. And we want to use behavioral insights to address different groups in society. And we also want to work with both new and established channels or contact areas to connect with the citizens, such as libraries, art exhibitions, pharmacies, and courses in community orientation for newly arrived immigrants. And we also strive to provide a platform for collaboration and to share experiences and good example, both nationally and internationally. So that was my last slide. Thank you for your attention, and please visit our website or contact me for more information. Thank you.
Thank you so much, Camilla. That was really clear, and it's really good to get an overview of what is a really comprehensive initiative, and also to hear a little bit about what's expected ahead. So we'll maybe hear more about it during the panel discussion. Actually, we're going to continue straight from Sweden to Bangladesh, and I'm turning to our next speaker in a second. Representing the Community Engagement for AMR Network, C4AMR, are Dr. Ramana Hook, who has recorded a keynote video for us, and Dr. Rebecca King, who will later join our panel discussion on behalf of the network. Dr. Huck is the Executive Director of the ARC Foundation, a non-governmental, non-political and non-profit organization dedicated to the socio-economic development in Bangladesh. Dr. Huck is also part of the C4AMR network. And Dr. King, who you will hear from during the panel, is the head of the Nuffield Center for International Health and Development, University of Leeds, and also co-leads the C4AMR network. So please, Eva, can you start the video? Thank you.
Good day, everyone. Thank you for giving me the opportunity to share my experiences of community engagement for tackling antimicrobial resistance in Bangladesh. Let me share my slides with you. Hope you can see the slides now. ARC Foundation, in partnership with University of Leeds, UK, led by Dr. Rebecca King, is carrying out a study called COSTAR. The aim of the study is to co-create, implement, and robustly evaluate an innovative intervention that addresses the contextual drivers of AMR through a One Health approach to community engagement and build an infrastructure for knowledge exchange. We expect that the findings of the study will ultimately impact on national and global policy. COSTAR has a number of components. Community dialogue approach is the key component of the study. To implement the study, we formed a technical working group involving the representatives of Ministry of Health and Family Welfare. We arranged regular meeting of the technical working group. We signed a memorandum of understanding with Communicable Disease Control Program of Ministry of Health and Family Welfare. We sensitized the district and sub-district level stakeholders. We selected master trainers, supervisors, and facilitators based on some pre-fixed criteria. Multi-sectoral involvement along with multi-layered training approach was adopted to ensure that the intervention is embedded within the existing system. We arranged community dialogues and we also arranged supervision meetings. A few enablers. The National Action Plan for containing AMR in Bangladesh doesn't have a comprehensive strategy for engaging the community to engage antimicrobial resistance. This created an opportunity to implement a community engagement approach that can effectively raise awareness, promote responsible antibiotic use, and foster behavioral change in Bangladesh. COSTAR utilized the existing resources within the health system to embed the community dialogue approach within the primary healthcare system in Bangladesh. This is the first time the communities are being engaged in an intervention to address AMR, which was very well accepted by the policymakers and also other relevant government stakeholders. So the ownership of the government, the support that we received from the Communicable Disease Control Program of the Ministry of Health and Family Welfare was the key enablers for the smooth implementation of the study. We also engaged other different stakeholders at different stages of the study as required. Community also took the ownership of the approach, which was the key enabler for the successful implementation of the study. Despite those, we faced a number of challenges involving the water, sanitation, and environment sector actors as the One Health partner was a key challenge. To overcome the challenge, we had to engage with these key personnel regularly, and we tried to motivate them to engage in the study and support us at different stages of the study. The facilitators also struggled to comprehend the complex messages of AMR. AMR itself is a complex concept, and due to the low level of understanding of the facilitators, they also face challenge to convey the messages to the community. To overcome this challenge, we arrange quarterly refresher trainings with the facilitators to discuss the complex issues and also help them to identify the future activities. We also observed a number of community dialogue sessions and tried to give the feedback to the facilitators to improve their facilitation of the community dialogue sessions. A number of facilitators also dropped out due to their workload, some other commitments. Some of them also lost interest to be engaged in the study, and a number of facilitators also migrated from the study area to other areas. To overcome the challenge, we tried to motivate the facilitators. We arranged regular meetings with them. We followed up of the community dialogue facilitators to make them active and actively arrange the community dialogue in their respective communities. The facilitators sometimes also struggle to motivate the local community people in attending the dialogue. To overcome this challenge, we engage with local key community stakeholders and some other local influential people, and also we contacted the community dialogue supervisors to help the facilitators to mobilize the community people. So all these key stakeholders within the community also supported the facilitators to arrange these community dialogues. These people also tried to motivate the community people to join those community dialogues in their respective areas. A few policy implications. Community engagement needs to be addressed as a key strategy for awareness building, education, and promotion of rational use of antimicrobials to tackle AMR in the National Strategy and National Action Plan of Bangladesh. These plans are now in the drafting phase, so there's an ample opportunity that the community engagement is addressed as a key strategy in this National Action Plan of Bangladesh for containing AMR. Embedding the community dialogue approach into the existing health system is really important to strengthen the system capacity and also for sustaining the community dialogue approach. Multi-sectoral collaboration for engaging human and animal health sectors is really important to develop contextually appropriate community dialogue toolkit and with a specific focus from One Health lens. Regular coordination and communication with the policymakers is really important to ensure smooth implementation of community dialogue approach. Thank you everyone for giving me the opportunity.
So we thank Rumana for that contribution, and it's really great to have Rebecca King also with us, and maybe we can hear from her also to elaborate a bit more on this initiative and the community dialogue approach. But I think we will continue directly now with our next speaker. So our next speaker for today is Florence Anam. She's the co-executive director at the Global Network of People Living with HIV, GMP+. Her leadership has been instrumental in fostering inclusivity and affecting positive change with the global HIV community. Please, Florence, the floor is yours.
I'm honored to be here and to join this meeting today. Thank you so much for having me. I will use the 5 to 7 minutes allocated to me to sort of share lessons on community engagement and leadership from the HIV movement, for which I have spent almost a decade, maybe a little longer than that in. I do not have slides, so just indulge me. I will try to be as connected with you as possible. I will first of all start by sharing that the HIV movement has continuously highlighted the significant role and benefits of having community at the center of the response. So these may just be words, but behind these words is a whole movement and a lot of work that went into advocacy and activism and pushing, and that continues to date to ensure that the actualization of community at the center of the HIV response becomes true. So the HIV community and civil society movement has always remained very consistent. It holds every actor in this response accountable to this. It could be from asking, why are we not in this space, or why is just one person in this space? We do not believe in there is only space for one. There is questioning around what is effective engagement of community and civil society in different platforms, trying to call out and doing our best to address tokenistic engagement of community in different ways. And so because of doing this, we are constantly redefining what it means for communities to be at the center of the response. So it may have started when I joined this field as just, being a service recipient and showing up at my clinic to take my medication, doing what the doctor says, taking my treatment as I have been told by the doctor, and that was my contribution, and has since moved and shifted and changed to a point where community have to own and accept that they are also responsible for their own health, positive health outcomes. So the agency that we are currently pushing on in terms of addressing community being at the center of the response. And so we have been consistent about requiring that our engagement is respectful, is deliberate. I have worked in this field when, community would be the last speaker, almost, an afterthought to an event, or just showing up into a meeting to just tick the representation box, to now requiring that interventions and experiences of communities be done deliberately so that they are actually making meaningful change, but also requiring that everything we do gives agency for our visibility and voice. So now we are shaping policies, we are defining programs, and the way we are doing this is right from the global level. So engaging with the high level meetings, for example, engaging with UNAIDS to develop the global AIDS strategy, doing community consultations at every level, requiring that this is done, and supporting and mobilizing our members to attend and engage in processes around developing the strategy, developing the indicators for the strategy. So going into different platforms, but that has also required that we build the capacity of our communities to be able to engage with this advocacy. Member state interventions and processes are difficult and highly technical sometimes, and so it requires that some deliberate efforts in funding and resources are made available for communities to invest in building their capacity to engage. So this has shifted how we do our advocacy. And I must admit, the quality of advocacy that we do in the HIV movement has moved. Even for me as a person, I started this work showing up into meetings to share my HIV story, tell people how I got infected, how they should be careful not to get infected, and how lucky I am to be alive. And where though these stories are important, the quality of my engagement now is different. I go in to use lived experience from a majority of people, packaged well in evidence, gathered and organized into graphs, into data sets that can be useful to quantify and make resource decisions and make program changes that can shift how the program works. All this is embedded in something we call the Denver Principles, which basically are 40 years old this year. And it was communities coming together to outline the rights and responsibilities of people living with HIV. And it provides recommendation to healthcare professionals, family, friends, or countries on how they shall engage with communities. So I can post the link to the Denver Principles on there, but it's 40 years old this year, but it is the foundation from which our work around the greater involvement of people living with HIV is embedded. And that's where our slogan of nothing for us without us, which guides everything that we do, comes from. I think effective advocacy and community engagement has to start from a point where we are all angry about something. And for people living with HIV and those affected by HIV, the experience of stigma, the experience of constant erasing of our being and our needs has pushed and continues to push us to want for more and to ask to be in the rooms and to ask to shape policy and to shape programs and to shape how service delivery can be responsive to our needs. I do not want to act like we are there yet. We are not. Far from it, because many of us continue to be excluded by law, by the system, by stigma and discrimination, and we must then therefore continue to fight. But we know that systematically coming together and organizing together is important. Something that I will say also is, how are we shaping language and discourse around community engagement? And so for us, I think the clear definition of what engagement is, community engagement versus community leadership. And community engagement is useful. It talks to task shifting, supporting health systems, it talks to program implementation, but there's a whole body of work around community-led advocacy, community-led research that we are losing out on, because then there's no space for it, and it's not quantified, it's not monitored, but its impact is complementary to the wins of the HIV response. The Global Fund came to being because of a big body of work that was community advocacy and activism. It continues to get replenished funding because community are at the center of working alongside Global Fund to make sure that countries are investing in the fund. So some of these things are how we have learned across time to make sure that we have to give the names to the work that community is doing, ensure that it is quantified, ensure that it is monitored. What is not documented did not happen. And so if it didn't happen, then the value of community work constantly gets erased or is not counted. I think I will stop there for now, and I'm happy to answer any questions. Just before I stop, I just wanted to share that this year, the World AIDS Day theme that has been released by UNAIDS is Let Communities Lead. There's been a momentum now acknowledging the role of communities in the HIV response. It is going to be interesting to sit here as we go towards the World AIDS Day and the next coming years on how to actually hold policymakers, countries, and decision makers into actualizing Let Communities Lead. Thank you very much.
Thank you so much, Florence. It was really great. And thank you for reminding us of many of those principles and what actually communities at the center mean. And also, I think there's a lot of transferable thoughts that you mentioned around the anger and the frustration of things not moving that I think the AMR community also can reflect on and relate to. And so much to learn from the fight against HIV. So thank you. And I hope we can come back to many of the things you raised in the panel discussion. So we move forward then to the final presentation. So last but not least, our next speaker is Daniel Waringi. And Daniel is the co-founder and head of programs at Students Against Superbugs Africa. He is the recipient of grants from the Foundation for Advancement of International Medical Education and Research, and towards Unity for Health and the Foundation to Prevent Antibiotic Resistance. So please, Daniel, the floor is yours.
Thank you so much, Christine. So I'll just start off. So thank you so much for the opportunity. It's a humbling moment for us to get to present our work in this webinar. So I'll go right to it. Just a minute. Okay, so about us, so Students Against Superbugs Africa is a catalytic youth-led initiative, and our work is aimed towards mitigating the threat of AMR in African communities. And we try to do this as much as possible through our One Health approach. So our strategy is anchored in 2 key pillars, and we try as much as possible to motivate or promote youth advocacy and blend it in with community engagement. So one of our strategies is capacitating young people to engage in AMR initiatives and at the grassroots level, and also we engage in some direct community engagement. So our primary setting is in Kenya, but our team is multidisciplinary, and we have some of our programs that have extended to other countries in Africa in collaboration with different institutions, for example, React Africa. So we are very intentional in terms of ensuring that we have a One Health approach, multidisciplinary engagement, and we work to build on existing work and depending on the niches of the people that we engage with. So one of our approaches is engaging with young people, and what we do before initiating any program, we try as much as possible to do some needs assessment and to identify some of the gaps that exist. And we try as much as possible to focus on the neglected areas in AMR. For example, recently our work has mainly tried to focus on non-STEM, that is non-STEM tertiary level students or tertiary level students who are not in medical schools. So we've tried as much as possible to see how we could actually bridge that gap and bring in other tertiary level students and early career professionals who are not really into the medical courses, and have them also share the expertise and engage in AMR. And so after that, we then co-design and implement relevant capacity building programs. So this is where most of our work is anchored. We do a lot of capacity building. We have different programs on this. And the aim is to empower the young people, equip them with skills and knowledge that they can then leverage on to actually go ahead and initiate their own community initiatives. Then we offer support in terms of designing contextual and pragmatic grassroots community engagements. And we try as much as possible to have them shaped like pilots so that at least we're able to generate some evidence, and hopefully we can have potential scale up from this. We support in terms of implementation and of these grassroots interventions, and we had to reach there. So the last point whereby we'll now, after we have kind of had most of our pilots implemented, we'll be doing some evaluation. And then this will help us in terms of setting pathways to ensure that we're able to scale up on our work, to ensure that we're able to integrate other fields. We've had a lot of some of the good work that is happening in the HIV and AIDS space, and so that we're able to ensure sustainability of our work. So we also do some work which incorporates direct community engagement, and we kind of, most of our work has been in urban informal settlements, and we conduct reconnaissance, we do some need assessment, and we try as much as possible to co-design some of the interventions which are actually contextual. I'll give a case example of a project that we did in one of the urban informal settlements in Kenya. And after going to the community, we realized that the main issue is not even about AMR, because we couldn't talk about AMR when we did not have WASH interventions in this area. So we decided, since it was the community's priority and what they really wanted was to have some of the WASH interventions, some good, some water, access to water, and also having some drainage systems. So we decided to focus on this and trying to come up with cost-effective, innovative solutions that they could actually access clean water, rather than going all above and focusing on AMR when the root of the issue is not yet addressed. So we pilot our interventions, and so most of the interventions are still at the pilot phase, and one of the aims that we have is to evaluate the impact and try as much as possible and disseminate the evidence that we'll gain for this. And we hope that this will help us also in terms of designing scale up. It will help us also integrate the community work with some of other community work that is happening in Kenya. And so that at least we're able to also loop in AMR into other ongoing initiatives at the community level, and that promotes sustainability. So these are examples of the projects that we've been doing. For example, we are very much focused in terms of establishing AMR clubs in universities, in different universities, in different countries in Africa, and also helping young people come up with initiatives, especially those ones who really are motivated, for example, non-profit organizations, community-based organizations, and also trying to have conversations and pilots around seeing how can we institutionalize some of the work that we are doing, for example, embedding AMR into, existing curriculums, for example, at the university level, and also doing some work around engaging with these secondary school students, developing handbooks and pre-testing them and seeing how we could actually use that as a tool to actually engage more secondary school students in Tanzania. In Uganda, we also train as much as possible to, from a behavioral science perspective, to try and investigate the motivators, factors, and barriers that hinder active student engagement in AMR. And after gaining this will also enable us to shape and strengthen the work we do so that it feeds into what the students want, and we're able to identify some of the barriers that they face and we're able to solve them appropriately. So in Cameroon, we're also trying to develop a sustainable scale-up on how we could actually engage young people in terms of mainstream AMR media engagement. So we have a team there that is working with some radio stations in terms of seeing how we could actually bring the media, mainstream media, into AMR conversations and to increase awareness on AMR in the country. In Kenya, we're also doing some work on trying to focus on the nexus between food safety and AMR. And the project that we're doing right now is trying to develop a pre-test module, engaging street food vendors and seeing how we could actually generate cost-effective, innovative solutions on how they could actually, promote hygiene and ensure that in a pragmatic way or in a realistic way, they're able to engage in better behaviors that promote food safety. And in Nigeria, we also have a pilot education program supported by Boston University in terms of ensuring that we have an education program that targets underserved populations in AMR. And we're also developing an on-site platform with some use in Nigeria. And also in Tanzania, we're trying to pilot and test innovative approaches for engaging community in AMR, especially in the urban areas. So we've done some work around WASH, that is in urban informal settlements, as I shared, and we've also supported various advocacy, youth-led advocacy activities, for example, AMR walks, and also different webinars and online campaigns. So this is some of the students that we're engaging in the different countries. So we try as much as possible to capacitate these students and have them start initiatives that are based on the interest. We don't dictate what they should engage with. So we leave it to them to decide, depending on their skills, depending on their expertises, and also depending on the needs that they have identified in their communities. What are some of the areas that they would love to engage in? So throughout our work, so we've been active for the past 4 years. So we've been able to engage in various community initiatives. And we've been able to also see some of the gaps that exist. And this is one of the things that I would love us, even as we come from this session, we're able to see how to go about this, because it's really a challenge. And these are some of the things that kind of hinder a lot of community engagement, especially in AMR. For example, we need to have discussions around how do we then ensure that we're engaging in a One Health approach, that at least we're also able to bring different stakeholders on board, and that we will be able to actually reach more people and have more expertise on board. How do we ensure that we have inclusivity and that the community we engage actually own the projects that we are doing? And I think the main thorn in the flesh, I think, which will also be discussed in the next webinar, is how do we measure impact? Because one of the reasons why we don't have a lot of initiatives in community engagement is because we are not able to measure impact. We're not able to show how do we then how do we count success in community engagement? And this kind of makes a lot of stakeholders shy away from investing in community work. And also we need to have a good case that actually helps in terms of domestic investment, for example, national government's investment, regional government's investment, and also something that also brings in different civil societies and makes them prioritize their community engagement in AMR as some of their key focus areas. And then we have a lot of work going on in the communities. For example, right now in Kenya, we have a lot of political will around working with community health promoters. So how do we ensure that we integrate AMR into other established interventions, so that at least we're able to ride on other existing frameworks in the community? And I think, how do we then balance context and scale up? This has been one of our key issues, because you have to ensure that the work that you're doing well targeted to that community, but then how do we ensure that we're able to scale up on this? And lastly, AMR is a complex
Sorry, Daniel, we're
issue.
having some problem with the connection.
Okay, can you hear me now?
Sorry, it's a little bit unstable. And could I please ask you to start wrapping up as well? We can hear you okay at the moment, but it's a bit unstable.
Okay, sorry about that. So I think I'm just finishing up. So I was trying to say we need to have more discussions around how we frame AMR, especially, how do we shape the narrative and the discourse of AMR in community settings. So these are some of our communication platforms. You can reach out to us, and thank you. And I'm sorry about the network issue. Thank you.
That's all right. Thank you so much, Daniel. That was excellent to hear the breadth of work that you're doing in so many different countries and the different types of initiatives. And you also touched upon some of the challenges you've been facing, which I think is something we will discuss a little bit more in a second. Before we do that, just as I've seen already, some people have been entering some questions in the Q&A. And so I'll ask you, before we move to the panel discussion, to place your questions to participants in the Zoom Q&A, and also write the name, if you don't have put your name already on the Zoom label to say your name and who you direct the question to, whether it's all of the panelists or one of the participants, one of the speakers. And then we'll select a few of those questions after the panel discussion that we're moving towards now. So really a big thank you to all the speakers already for summarizing in a few minutes what is very much complex initiatives. And I think if I would invite speakers to put on their screens, please. Thank you. And we also now have Rebecca King with us. Welcome to you as well. So I think if we can start with the first question, and in the meantime, please go ahead in the audience to ask your questions to the participants, and we'll pick up that later. So my first question actually to the panel is something that many of you already have touched upon. You all hinted to successes and challenges that is relating to your work and the initiatives that you work on. But if you were to highlight one key enabler and one key challenge in the context of the community engagement work that you're doing, that you think that have been particularly important, it might be hard to choose one, but try. Which would that be and why? And if I may, if we can start perhaps with Rebecca.
Thank
That's
you.
okay?
Can you hear me?
Yes.
Okay, well, thank you very much. I would just like to thank you for the opportunity for us to present, and thanks to the other speakers. They were such interesting presentations. I know that Romana, my colleague, has mentioned in her presentation that a key enabler for us is this idea of community ownership. And I think that's something that I'm sure will resonate with the other presenters as well. But I'd also like to highlight, because we have been implementing a similar intervention in Nepal, so we're doing this across 2 settings. And a very critical enabler for us in both settings, and especially in Bangladesh actually, has been the extensive support from the Ministry of Health and Family Welfare. So they have really taken ownership of the intervention. So they talk about the intervention in terms of something that they are implementing with some technical support from ARC and University of Leeds. And there's a very strong relationship of trust there, very, very supportive at the central and the district and local levels. So I really think that that has been incredibly important in terms of enabling the work that we're doing and enabling, it might be early to say the success of the intervention, but at least the process of the intervention we're still evaluating. So that would be a very key enabler. And as a result of that support, we have been able to embed very carefully what we're doing within the existing infrastructures, mostly of the health system, although we tried very hard to take a One Health approach but every element of the approach in terms of training, in terms of monitoring, in terms of supervision is embedded into the existing infrastructure. And that, of course, wouldn't have been possible without that support from the ministry. Did you ask me to mention the challenge as well? Or okay, so I think probably again, I should say one challenge, but I might say two. One of the challenges, which I think has been hinted at as well by Daniel, is just the complexity of the concept of AMR, and how do we approach this very difficult topic in a variety of settings. So just to begin the process of classifying medications and to be able to explain and emphasize that you have different types of medicines, antimicrobials, antibiotics, etc. To start from that and then to get this concept of resistance into language, concepts, terminology that is accessible to people with different backgrounds and experiences. So that's one challenge, but the other challenge that I'd like to highlight as well is that our intervention has really focused on developing what we're calling community-led solutions. So dialogues whereby people who are participating in the dialogues are themselves proposing solutions to the challenges of AMR in their setting. But of course, the system can't always respond. So that is a major challenge. Some things people can respond to within the context of their daily realities, but some things you need a systemic response to, and that will be future research, I think. So that's a challenge. Thank you.
Thank you so much, Rebecca. That was really great. I think you also related back to what has been mentioned by Florence, among others, about the importance of community-led, and as Daniel also mentioned, in being involving communities in the design of the program. So I'm moving actually to Daniel next, if that's okay.
Yeah, so thanks so much, Kathleen, for that. So I think our major enabler has been, I think, working with young people. And I think we've had a lot of warm approach. Most of them have really embraced the issue of AMR. And I love how they do own the problem and realize that this is something that they actually need to work on, to this something that they need to actually invest their time, invest their resources. When we started, we were a bit skeptical, because we have so many other competing priorities, and I would say other areas which are more lucrative than AMR, which people would actually prioritize. But I just love that, we have so many young people who are actually willing to address the neglected problems, for example, AMR, and they go right into it. They invest a lot of time onto that. So maybe for a challenge, I would say, is getting it right. I think it's kind of very hard to get it right in AMR, because one is that, AMR by itself is a very technical issue, it's a very complex problem. As we go into the communities, it's easier to engage with students, especially medical students. But now when you start going further among other students, then you really need to have a very good value proposition, and you need to identify things that they can actually relate with in their day-to-day setting. So this is quite difficult, and in the communities, I think in as far as possible, you want to engage with the community in terms of co-designing solutions. Sometimes there's that gap in terms of knowledge, and you would want to engage them in everything, but at times, they might not have that knowledge. So we really try as much as possible to bring it in from a level that they understand, but sometimes it's actually a bit hard to actually generate, impactful interventions. Thank you.
Thank you very much, Daniel. I think there's a lot of cross-cutting issues coming up here from what you've said. And I just, despite your different initiatives, I'm curious to hear from all the speakers. So I don't know if we have Florence back online. Thank you. Great. So Florence, if you already mentioned also challenges and some of the enablers, but if you would have to highlight one that you throughout your experience, and that might also be really relevant for AMR, what would you highlight as a main enabler and one main challenge?
I think an enabler would be the definitions. So what is community in AMR? Because then we remove the confusion around who is representing. And I think to borrow from some of the work that we have done is to also develop, be it a checklist or some guidance that gives the bare minimum of what engagement or inclusion means for communities. And I know I'm happy to share some links with you to share with the team, but we have, from a global perspective, Stop AIDS, and a few partners have developed those for the high-level meeting we just came out of, but also the Young People Network, the global network of young people living with HIV, have what does it mean to engage young people? And so on there are definitions, and there's clarity around what engagement is. Young people don't want to be volunteers, they want to be paid. You know, if someone is coming onto a call, for example, for you at the office, it's easy. For them, it means they're, you know, not doing 30 minutes of work or an hour's work. So so that definition, I think, engage from the start is the next enabler. So whatever process it is. So I'm excited to learn that the high-level meeting on AMR is happening next year. It's tedious, and I'm going to say experiencing the high-level meeting on PPR and UHC this year, there's no space for community, but you have to push anyway, because even if it's just a line, there's something to start the conversation on. So just start from the beginning and not wait until the efforts are at country level to start pushing, but the discourse and the actual commitments happen at global level. So some investment to ensure communities also at that level is critical. Yeah. So I spoke about enablers. I think challenges would be funding and effective funding. And so always constantly pushing to ensure that there's consistent funding for community engagement.
Great, thanks, Florence. I think that's really an important challenge to overcome. Absolutely important to mention. I move then to our last speaker, Camilla. You've been listening also to other speakers. What comes to your mind as the really highlighted enabler and challenge?
Well, for us, I believe a key enabler has been to work really, really close with the different groups in society that we want to connect with, and to listen and be able to understand their drivers, and then be flexible and adapt our interventions to their context and needs. And just to give you one example, originally we thought that all organizations that were going to fulfill the criteria we developed would be named Antibiotic Smart. But during the development of criteria for preschools, we realized, talking to the preschool staff, that, and this was perhaps not so surprising, but that the issue of AMR is quite remote for them. For them in their daily work, it's much more important, so to say, for them that the children and that the staff are healthy and that they prevent the spread of infections. So to be relevant to them, we decided that the preschools fulfilling their criteria, instead of being designated Antibiotic Smart, they will be designated as healthier preschools. And this turned out to be much more motivating title for them. So listen and adapt, I believe, is keywords here. And one challenge, and I hear that other people talk about that as well, a major challenge, I would say, has been to get different groups in society to prioritize to work with or against AMR. And to give you one example here, we work close with schools and teachers. And I mean, they have so much to teach about, they have so many exams to correct, and they are simply very busy. And to squeeze in educational activities on AMR is difficult for them. And there are also other societal challenges that the schools should teach about and arrange activities around, such as drug abuse and mental health, for example, and how should then AMR be prioritized compared to these other important issues? So I believe that one key enabler, and I think you mentioned this as well, Daniel, but is to ensure that education about AMR is included in the school curriculum, and not just in natural science, but also in other subjects. So that is one enabler, I suppose, and also a possibility to include AMR in the teachings of other societal challenges, such as health or sustainability, which are, of course, also connected to AMR. Yeah, thank you.
Thanks a lot. Yeah, it's really great. I think we might just move on to the next question, and I see already a lot of questions are coming in from the audience. So I think we'll do one more question, and then we'll move to questions from the audience. So actually, we reflected on some of the principles, and some of you mentioned when it comes to community engagement, which has, community engagement has lately gained more recognition in global health, not least during or as a result of the COVID-19 response and the importance of communities during that. And also the UN Interagency Coordinating Group on AMR in 2019 recommended a systematic and meaningful engagement of civil society groups and community as a key process in the response to antibiotic resistance at global, regional, and national and local levels. However, we know that full recognition and acknowledgement is not always easily gained everywhere. Some of you have alluded to that, the recognition challenge. And so my question to you, brief answers would be great. In your experience, and how recognized and acknowledged would you say that community engagement is in AMR or in the field of HIV in the case of Florence, and especially at the decision-making level, the decision-making level that is related to your work? So to what extent would you say that your community engagement work is recognized and acknowledged? I think we can start this time with Florence, perhaps.
I think it depends on the different platforms. So I will just look at it this way. So if you look at the big decision-making bodies, there's always a community delegation. So you have the community delegation of the Global Fund, you have the community delegation of the UNAIDS, the PCB, you have, whether it's UNITAID. So it's a group of regionally, population-based representatives who have one person and an alternate sitting in the board. So that is from the spot from which we start to monitor engagement and how effective it is. But further down to country level, the PEPFAR COPs, for example, where decisions around national programming for HIV happens annually or now every 2 years, has a strong community component. Used to be one person living with HIV and one civil society representative. Now it's almost about 6 or 7 per country. And that's why I say we are constantly pushing for implementation of having more people and more diverse voices into the room. Similar to Global Fund, we used to have people in the community coordinating mechanisms of the board. So it's depending on who. Currently, the high-level meeting political declaration on HIV has targets on community engagement. The 30, 60, 80 is very clear. How many 30% of testing shall be community driven, 80% of service delivery shall be community driven. So these are targets that member states have committed to, and they're targets we pushed for during the Global AIDS Strategy Development process and the political declaration. So now we can define what that means at country level and begin to hold people accountable. So that's why I started with, you have to start at the top, but it's different mechanisms at different places. I will say that it doesn't come easy, but what we have learned is if it is not indicated in the measurement mechanism right from start, then no matter what you do, it's tokenistic is defined, but there are different pieces and work that I think is quantified. The people living with HIV stigma index is another one for which all the data on stigma and discrimination is used, and highlighted for addressing stigma through the UNAIDS report, etc. So I think whereas implementation is important and very much needed, even for AMR, the aspects of community literacy and awareness and demand creation are important. It is critical that we deliberately document these pieces of work, but not to lose it's easier to document the program implementation work. It's harder to document the advocacy work, but it was to push that both are actually, documented and measured.
Thank you. Yeah, that's really important reminder, representation and active participation in governance structures. I turn next to Daniel. What about you? What is your experience with recognition and acknowledgement of community work that you are doing?
Thank you. Thanks so much. I think I'll maybe recount what Florence had said. I think we need to understand the meaning of engagement. And I think at the decision-making level, most of us really don't understand what community engagement is. And this kind of hinders how we approach community work. So I think it's not really much, because even at the national level, if you look at our national action plans in many countries in Africa, yes, there's kind of a mention in the objectives on the importance of educating the public on AMR, but then there's not like a lot of effort going on. Most of the time, I think we have a lot of campaign that is going on during the World Antimicrobial Awareness Week, but really throughout the year, we don't have a lot of work going on in the community. I really don't maybe point out fingers, because AMR space is quite a quagmire, because, some of these lack of prioritization is because at the moment we have very little funds. So other areas are kind of seen as higher priority as compared to community engagement. But then I think to kind of look behind it is that the reason why we don't have enough resources being driven into AMR is because most stakeholders are not aware of the dire threat of AMR. Not really many people understand the need to invest in AMR mitigation. So that kind of backlashes us, because if we don't then engage the community, then it will be very hard for actually other people to understand this. So I don't feel that we have a lot of appreciation of community engagement at the decision-making level, and especially at the national level. I feel there's need to do more, especially in terms of domestic financing and investment into community work. And I think a low-lying fruit that we can focus on is not really recreating the wheel, but looking at what other existing initiatives, what other community engagement activities do we have? Can we try and loop in AMR and see how it goes by? And then I think using those as pilots, we can then advocate for more community engagement in the coming future. Thank you.
That's great. Thanks for that. I think that it's really something that many of you have mentioned around investment in community engagement, and not expecting volunteerism only. I move next then to Camilla to comment on this, please.
Well, I agree with the other speakers here. I believe that community engagement is not as prioritized as it should be. And also, I think it's a problem that for the AMR issue to be prioritized in different sectors within the society, since it's a complex problem, it's important that it's also being acknowledged and as a complex and an important issue at the governance level in Sweden, for example, our municipalities and regions, for things to happen in other in different sectors in society, so to say, and in order for politicians and others to prioritize it, I believe that they must understand why it is important to them in their context. And so I believe they need motivation. What's in it for me? Why should we work against AMR in my context, in my municipality, or whatever? So I think our role here is to talk about community engagement, but also to be better at building knowledge and awareness at the decision level, making level persons, to help them understand their role and why it is important that, for example, the whole community contributes. So I believe that they need motivation, they need research results, and they need impact to be measured, etc. And so that they can motivate others in the society to engage. I believe. Thank you.
Thanks. I think this is something that this webinar series will come back to, about impact and measuring impact. So finally, last but not least, turn to you, Rebecca.
Thank you. I'll try to be concise. I think that others have also mentioned it does depend what we mean by community engagement. And obviously there are different ways to interpret engagement. So I think if we're talking about that kind of very sort of light level of raising awareness, giving information, etc., then there's a priority around that. You see it in all of the global and national action plans. But I think what most of us are trying to do is to go for a much more engaged bottom-up approach to addressing AMR and working with different stakeholders in community settings to identify solutions to the problems that are implementable, feasible, acceptable, etc. So I think that broadly there is less emphasis amongst decision makers in that area, probably, as other speakers have alluded to, because it's perhaps less well understood, perhaps there's less evidence in that area, less understanding about costings, etc. So one of the sort of areas that we see for AMR want to push is the importance of this approach. But then I would like to say that's a sort of a broad take on the question. But in terms of the work in COSTAR that we're doing in Bangladesh and Nepal, I think I mentioned that the key enabler has been the buy-in and the support and the trust with the ministries at all levels. And so I think there is a really good acknowledgement in those settings of the value of community engagement of the type that we're trying to do. But of course, we as researchers and our partners in the ministries are very interested to see what the evidence looks like. So we're not at the end of the conversation. Thank you.
That's great. No, we're not at all. Indeed, the end of the conversation. I think we're getting to slowly to the end of this conversation. But before that, we really want to have opportunity to raise some of the questions that the people in the audience have asked you. So I'll start with a question from Leong Nguyen Tan To to Rebecca and Romana. So in the presentation by Romana, Romana mentioned about contextual drivers of AMR. So the question is, what are they and their importance to contribute to the AMR situation in Bangladesh, and how the intervention has helped to address them?
Thank you very much. That's quite a big question, and there could be quite a big answer, and I don't think there'd be time for too big an answer. So I just would like to say that the kind of emphasis in COSTAR is about context, which is why we're implementing in two different contexts. So we've spent a lot of time at the outset of the study looking at context and what specific drivers might be. And we've used a variety of research methodologies that I won't go into here. But it comes down to looking very carefully at the One Health drivers. So looking at elements around human health and the behavior of humans in relation to their health, around animal health and the way that humans behave in relation to animal health, and around environmental health. And the contextual drivers can be quite different. We see quite stark differences in urban and rural areas, for example, and in Bangladesh, which is quite a different environment from where we're working in Nepal. Although we may think that the countries are close together, but they're very, very different cultural, health system, topographical contexts. So some of the drivers, just to be brief, would sort of perhaps coalesce around treatment-seeking behaviour for humans and for animals, how the health systems are set up. For example, can you access free medication? Where from? Can you access providers that can give diagnoses and prescriptions, or do you need to access pharmacists or informal sellers of drugs for humans and animals, etc.? There's a lot that I could go into there. But to come to the part that perhaps you're interested in is what has the intervention been able to do about that? Actually, I can't say yet because we haven't completed the evaluation, so I don't want to give a misinformation. But one of the things that we have been doing as part of the monitoring is to collect what we call decisions that are made in the context of the dialogues. And we have some good data on those decisions. And what we've noticed is that a lot of the decision making so far has been around treatment-seeking behaviour. So it's been around people talking about accessing providers that are qualified to offer prescriptions, about getting prescriptions and using prescriptions, and about completing doses and about not sharing. So, but I have to say that that is reported, it's in decision logs, but we're still going to be evaluating the extent to which we think that has actually happened. I hope that answers your question in part.
Great, that was really good, comprehensive answer. I think indeed it's a wider question. So thank you for that. I have a question here also from Eric Venant to Florence, and who's asking, how is the current situation in terms of HIV drug resistance, and how is it addressed and managed at the community level? If you can say something about that.
So I think depending on the country, it depends on the country and what interventions around treatment literacy exist in that country. You'll be able to see a lot of conversation around adherence and resistance. Also, I think if we are talking for ARVs, there's been a lot of push around getting treatment that does not get, people into forms of resistance. So the optimized drug movement and push, and now the dolutegravir that people are taking has, minimal aspects of resistance as compared to previously. I don't think there's a lot of investment as such around treatment literacy these days, and it goes to the reduced funding for community interventions. However, there's a lot around keeping people in care, keeping people adherent. I just want to highlight that in July, WHO released a policy brief that further defines with clarity the difference between unsuppressed, suppressed, and undetectable, with the various readings of different viral load tests. Within this, there is an opportunity to talk to people around, if you're unsuppressed, you have high chances of getting viremia, so then you need to make sure you're remaining adherent to your treatment so that you get to the undetectable level. So these conversations are still a little bit away from people, but depending on each country and how much they give towards community interventions, you will be able to see certain conversations happening. So a lot needs to be done, but it's there in little pockets. Yeah,
that's great. Thank you. Yeah, so I think that this next question, we can. It's actually directed to everyone, from Wesal Saman from ICARS, and he's asking whether there are specific methods that you apply in order to identify the relevant communities for your engagement initiatives. And maybe we can start. Who wants to start? Daniel, okay to start?
Thank you. I think that's a good question on how to actually distinguish between stakeholders and the community. I think it's kind of a thin line, but it also goes, the community is also, I believe, is also the key stakeholder that you want to engage, because if you want to co-design interventions with them, then you have to also bring in and have that mind frame that they're also a key stakeholder in what you're doing, that you're not just designing interventions for them, but you're actually co-creating solutions with them. So to say, I think it's a blurred line, because on my end, I think community, in as far as you're also engaging them, they're also a key stakeholder. And I think when we have that that understanding, it makes us even engage the community in a better way. You know, we see them not just as maybe people whom we want to impart solutions on, but people whom we can actually partner with to generate interventions that can actually work for them. And I think this is very important, because that way we're able to bring in the ownership, which is actually very important if you are to ensure that we have sustained community interventions. So I think I will answer it that way. Maybe in terms of stakeholder mapping, I think it's, but I feel we shouldn't really sideline between the community and the stakeholders. Let's have the community as our key stakeholders, so that at least we're able to bring in that co-creation and engaging them actually when designing interventions. Thank you.
Great, that's really clear. Is anyone else want to comment on this question? Rebecca, go ahead.
Thank you. I think it's a really important question. I'm a social anthropologist by training, so kind of thinking about who is the community is one of my favourite things to dwell on. I just wanted to say that in the context of the CoStar intervention that we're implementing, I think we are simply referring to people that live and work in a given geographical location, which I realise is a very simplistic definition of community. However, the element of that is not simple is when we think about inclusion, and how can we really think about, have we been able to engage and include people from different parts of different communities within that geographical setting. In Bangladesh, we think it's less complex than in Nepal because the population where we're working is relatively homogeneous. So we focus very carefully there on inclusion in terms of gender and age. And we are very much aware that there are less visible ways to be excluded. So we try to learn and to consider and to reflect on that. And that also will form part of our evaluation. In Nepal, we build in the complexity of it being a very heterogeneous population. So different religious, ethnic, caste groups living within one geographical setting. And so we've tried to address that as well in terms of the selection of facilitators and the location of the community dialogues. So I think it's a very important question, and it's another one of these that we probably will never come to the perfect answer, but we have to be very open to constant reflection and learning and thinking about inclusion.
Thank you. That's a really important point to raise about equity and inclusion. Florence, did you also want to comment on this, I think?
I think just to piggyback on what Rebecca said, because I was going to talk about inclusion. I think I'll just say also the levels, because you have the expert communities and then you have the not so expert communities. And I walk into sometimes webinars where there are like 3 levels of a conversation in one, because so sometimes that can also be exclusionary. Like you have people in the room, but the conversation is really far removed for them to actually engage meaningfully. So I think just to create the awareness that there is levels even within the communities that we want to address. And then to just also stress that from my end, we are by 4 people living with HIV, by people living with HIV. So ours is pretty much clear. And you would think that that is easy, but I just wanted to share that even from our end, we have to constantly check ourselves to ensure that the truthful representation is actually in the room. Yeah.
Really important reminder. Thanks. And Camilla, did you want to comment on this as well?
Well, I believe my peers here has given good answers to this. So I'm not sure if I can contribute anymore, but thank you.
No worries. Absolutely. I think we will need to start wrapping up. And actually, I just had one short question to you all, and maybe you can answer 2 questions in one. It's about how we ensure the positive examples from community engagement and how they're harnessed, and which I think you're all eager to do where you work. But in your view, what would be an effective and efficient platform? What would it look like? And also, would you say that we have today enough community engagement on antibiotic resistance? or do we need more? So there's two questions in one for you. Who wants to go? Camilla,
I can go first. Well, to answer your second question, if we have enough community engagement today, and I say, of course, I say no to that question. And I guess we are all here because we agree on that. Regarding platform, I believe it's a tricky question, but I think a key enabler is to spread success stories. And I think that today's webinar is a good example. I think we should do it more and perhaps more systematically, and to give to gather a toolbox or something and lesson learned, etc. But also, and I will come back to that next webinar, but also to report on the impact of different interventions. So we spend our effort and our money on good intervention that we know have an impact on society. Thank you.
Thanks, Camilla. I think I see Andrea, we have to wrap this up, and I think it seems like maybe the last question was a bit leading, and we all can agree that more community engagement is needed in this space. So I'll actually have to wrap this up, and it's been really a rich conversation. So thank you to all the speakers. It's really a lot of important points have been made in terms of the challenges and enablers, ranging from the complexity of AMR and the language complexity around it, the funding challenges, the challenges of ensuring inclusion, but also the enabler involved, but that involves co-ownership and the importance of that. So I think, yeah, I'll hand over to Andrea to also say a few concluding remarks. Thank you.
Thank you so much, Justin, and I want to echo your thank you to the speakers. This is a very excellent conversation and really enriching, and also learning process, I guess, for everyone here. I also want to thank the co-organizers, which are sitting beside me, Maria Prenting from REACT and Antibiotic Smart Sweden, and Eva Garmendia from Uppsala Antibiotic Center, which helped all of us in making this possible. I agree with Justin with your highlights, and I took plenty of notes as well, so I don't know where to start. I just want to mention that we have a few answers today that perhaps we didn't have before when it comes, for example, to the need for a clear narrative. Also, when we discuss about community engagement versus leadership, it might be clear in some cases, but also when we specifically talk about antibiotic resistance and that type of community, we do need that type of clarity and narrative. Also, as you also mentioned, the involving different parts of the community and striving for equity and equality, and including both youth and gender. And I must say that we had, for this specific webinar, a lot of students joining, not least one of our panelists. And this has been excellent to see that type of interest, and we want to keep engaging also with youth representatives. We also have a few questions that I would say perhaps haven't been answered, and that are leading up to the next webinar as well. So how success look like? How do we measure impact? What type of indicators do we already have, and which one are more meaningful when it comes to community engagement? And not least, I think was mentioned by Florence, also how we quantify and monitor, which I think also it's extremely important. And someone else was mentioning like having a checklist, which I think it's absolutely great. And not least making the investment case when it comes to community engagement, specifically for antibiotic resistance. With that, yeah, I want to say that Eva is going to share a link in the chat right now for registering to the next webinar, which will be on the 25th of October. And you will find the registration and the recording of the webinar on the REACT webpage, and as well on the social media accounts. And last but not least, I want to thank everyone who has participated to the webinar for all the important questions that were asked. And we're going to take the questions in account also for the upcoming stages of the initiative as well. Lastly, in the coming days, you will receive a short evaluation questionnaire about these webinars. So it would be excellent if we can receive your feedback. So please just spend probably like a couple of minutes answering that, and that can help us for the upcoming events. Thanks again, and we wish you a good day, afternoon, and evening. Thank you.